Thank you so much, Dr. Cyrus, for including me in your course. So, I've been asked to speak something about subluxated cataract management. So, I'll be sharing a video with you. So, this is a case which had traumatic subluxation of the lens, and you can see there's another problem is there is a fibrotic anterior capsule which is there, and there is subluxation which is more than 5 to 6 log hours. So you need to stain anterior capsule well before you start creating capsular rhexis. And the problem in these rhexis, in these kind of cases, is that these are fibrotic areas. If you try to make rhexis through these fibrotic area, it may extend in periphery. So the principle is that whenever you have a fibrotic area, you need to cut through that area, and if you get a clear area, you need to make rhexis freehand. So here, and you may need to use micro scissors through different angles, through different ports, depending on the site where you need to approach. So here, I go ahead and trying to fashion capsular rhexis in this area, which is a little bit clear. So slowly and slowly, I initiate capsular rhexis. Again, put OVD, change my hands, and reaching in the area where fibrosis is there. So you need to use bimanual technique, hold with my right hand the rhexis flap, and in my left hand the micro scissors. So you cut through these fibrotic area. So you need to change your angles time and again, but you need to be patient. Once you reach in the area of subluxation, remember that you are going to use capsular hooks to stabilize lens in the anterior-posterior direction. So you need to have good rim of anterior capsule here. So be careful about that. Again, cutting through fibrotic area. Changing hands again. So in the end, you have a capsular rhexis which is of adequate size. And go ahead and paint viscoat there, because the vitreous, it may prolapse if there is any fluctuation in the anterior chamber. So go ahead and put some viscoat before you go and stabilize the lens there. So these are the capsular hooks which are used here. Depending on the area of subluxation, you may need to use 3 or 4 capsular hooks. So these capsular hooks, they act like artificial zonules there, and they anchor the capsular bag in anterior-posterior direction, so that when you are doing nucleotomy, all the forces are not going towards the equator. So once you have these capsular hooks in place, this is the kind of brittle cataract, white cataract. So go ahead and do nucleus chopping and take out the entire nucleus. So there is nothing great in this. But remember that when the time comes, you need to come out of the anterior chamber. You always do visco exchange before coming out, because at this time, see, the bag is also collapsing, so capsular hooks are also getting loosened up there. It doesn't matter, they have served their purpose. So once you have done nucleotomy, go ahead and do visco exchange before you take out your phaco probe. So I go ahead and do visco exchange, turn off my fluid so that capsular bag is formed there. And after that, you can take these capsular hooks off. Now you need to put a CTR ring to give equatorial stability to this capsular bag. So go from side port and thread the capsular tension ring in the capsular bag. It's always advantageous to put a Q-glance hook through side port and guide this trailing eye of the CTR ring. So once this CTR ring goes in capsular bag, it gives good equatorial support. Bag is stretched and you have a good centration. Do meticulous cleaning of all the cortical matter. Again, maintain the anterior chamber. It's very important. Because the subluxation area is more than 5 to 6 clock hour, you need to stabilize the capsular bag by anchoring it to the sclera for long-term stability. So either you can use a Cioni CTR, or it's easier to use this capsular tension segment. So this is a segment made of PMMA, and it has an eyelet which stays above the anterior capsular access margin. So you go ahead and put 90 proline suture. You tie a knot here and put this segment in capsular bag. And after putting this in capsular bag, make sure that this eyelet which is there, it remains above the anterior capsular access margin. And you go ahead and go 1.5 2 millimeter behind limbus and railroad this 90 proline suture. So once you railroad both the arms of 90 proline suture, you go ahead and tie suture there, titrate the tension which is adequate. And cut the knot. Then, as this was a traumatic subluxation, I decided to use a single piece acrylic IOL here. And if it's a progressive kind of subluxation, you may use a 3-piece IOL. So the IOL goes in capsular bag and take off all the OVD and hydro stitch all the incision, and this finishes the case. So thank you very much, Dr. Cyrus, for giving. So now we have stopped using 90 proline suture, and in place of that, either you can use Gore-Tex, which are non-degradable, or I started using 60 proline for flanging, which is even cheaper than Gore-Tex sutures. Thank you very much.
I think that was a very nice video which you showed, like, means how you can create such a difficult situation, you made it look very easy. So I think the skill involved was extreme in that case.
Thank you.
So you could have done something else in this case, like you could have, like, the cataract was so hard. What are the backup plan you had in this case? Supposing you couldn't have managed to salvage the bag, what would you have done?
So then my preferred method is Yamanese.
Yamanese technique,
yeah.
okay.
So that's what I use. But here the cataract was brittle, no? It's a white, softer kind of cataract. But of course, you need to have all the backup plans in place, and you should discuss all the plans before you take up the case for surgery. True. That anything can happen.
Right. Any of your...
Yeah, so the retina perspective is different now. So when you have so much complications, I think saving the bag would still be the first choice, as it showed beautifully. But then if all goes well, it's nice. But in aphakia right now, my choice is CMT flex, because there are various modifications of the flange, flanging the sutures, flanging the haptics, I think. So, but I think, like Vasavada sir says, we'll have to wait for the long-term results. Anything that is proven more than 5-10 years, I think we'll just have to wait for all the long-term results.
Your lens, if you have a 3-point fixation, if you have those two are coming, if you have one more coming superiorly at 12, would that give a better fixation? Because we're all worried about the tilt. So if you have 3 flanges coming out, like you have those 2 coming out, you could have one coming out at 12, that. How about that as a modification of your lens?
Yes, it's a good suggestion, sir, but we'll look into it. But right now, the study that we're doing is also going to see about the barometry and see how, is there any tilt and is there any astigmatism cost? Because basically, we had the prototype design, and then this was almost the third design, isn't it?
Right.
So because of the fixation and because of the 23 gauge and the thickness of the stem, there has not been any tilt, isn't it? But I think when the study comes out, I think we'll have more data on that, whether it's causing any astigmatism. Harshul should start using it next time and showing it.
Yeah, of course, yeah.
Harshul, what is your opinion about posterior fixated iris claw lenses? Are you doing that, or?
No, I don't do that.
So your preferred option in a patient where has no capsular support, which is your IOL of choice to go to?
It's a 3-piece and Yamanese.
That's it. Okay.
Yeah, fine. I find once you go through that, initial phase, it's very quick and it's very easy to do. Yeah.
Any questions from the audience?
Yeah.